Thank you for the kind invitation. I have my note. Today, I would like to talk to you about the role of anesthesiologists in improving postoperative outcome for patients undergoing thoracic surgery. The ERAS and more recently PROSPECT guidelines have proved effective in reducing hospital stay and complication rates. In this presentation, we will focus on the various elements controlled by the anesthesiologist that can impact postoperative rehabilitation, such as different local regional analgesia, techniques, the individual PEEP in one lung ventilation, and the use of the lung ultrasound score as a predictor for postoperative pulmonary complications. The local regional anesthesia techniques used in thoracic surgery include thoracic epidural, paravertebral blocks, erector spinae plane blocks, serratus anterior planes block, and we talk also about intercostal nerve blocks and the intratracheal opioid administration. The thoracic epidural involves placing a catheter in the epidural space between the dura mater and the posterior longitudinal ligament. Thoracic epidural remains the gold standard for open thoracic surgery. It's also effective for video-assisted surgery. Due to the minimal invasive nature for that, it may always be necessary and can present risk. Epidural have potential complications such as epidural hematoma, abscess, hypotension requiring invasive monitoring, urinary retention, necessary catheterization, mobilization weakness that may hinder early mobilization. Furthermore, epidural catheter can be placed in patients requiring perioperative antithrombotic therapy. The paravertebral blocks provide unilateral analgesia for both somatic and sympathetic nerves that can be performed under ultrasound guidance. For the parasagittal approach, the ultrasound probe is placed vertically about 2.5 mm from the spinous process. This view allows visualization of the erector spinae muscles. You can see, I don't have the... You can see the paravertebral, the erector spinae muscles, the vertebral process, the costotransverse ligament, and you can injecting the local anesthetic here when they push the pleural and expand the paravertebral space. This block has been shown to be as effective as thoracic epidural for pain relief after thoracotomy, and regarding postoperative pulmonary complication, it yields similar spirometry. Complications of paravertebral blocks include perineural hematoma and infection. The cessation of antiplaquette and anticoagulant therapy should follow the guideline for deep blocks. Paravertebral blocks can also be more challenging, time-consuming compared to the other regional techniques. Erector spinae planes block involves injection of a local anesthetic or placing a catheter beneath the erector spinae muscles located above the transverse process. Erector spinae muscle is here, transverse process is here, and the local anesthetic is injected here. Continuous erector spinae plane block has been shown to provide analgesia and similar opioid consumption compared to the paravertebral blocks and thoracic epidural analgesia. Continuous erector spinae plane block improve postoperative recovery after VATS. The erector spinae plane block is easier to perform, has a lower failure rate, and it's considered safe to read distance for neural and pleural structure. Serratus anterior planes block. It's a block performed under ultrasound guidance with the patient in the lateral decubitus position. The probe is placing longitudinally at the level of the 4th and 5th ribs along the mid-axillary line. The local anesthetic is injected beneath the serratus muscle and between the lacetus dorsis and serratus muscles. The ribs, 4th and 5th ribs, serratus muscles and the lacetus dorsis, and the injection can be made here and here. These blocks provide analgesia to the lateral cutaneous branch of the T3 to T9 intercostal nerves without sympathetic blocks. The blocks reduce opioid consumption compared to placebo and can be performed before or after anesthesia induction, improving patient comfort and reducing anxiety. However, the duration of the analgesia is limited unless a catheter is placed for continuous infusion. Another limitation is that the serratus plane block does not cover the posterior cutaneous branch of the intercostal nerve or the visceral branches. Intercostal nerve blocks. Intercostal nerve blocks are easily performed by the surgeon by injecting local anesthetic directly into the intercostal space during surgery. They can also be performed by the anesthesiologist under ultrasound guidance. The block provides significant pain relief in the first 24 hours postoperative, particularly for parietal pain. However, opioid consumption remains higher than with erectospinae muscle blocks or paravertebral blocks. There is also an increased risk of local anesthetic toxicity due to this high vascularity of the intercostal space and systemic absorption. Intrathecal morphine. Intrathecal opioid administration is highly effective for postoperative pain management. The techniques in sample has a low failure rate, is cost-effective, and has relatively few complications. Low dose of morphine, up to 150 micrograms, does not increase the risk of respiratory depression compared to systemic opioid administration, and do not require continuous monitoring in the postoperative unit. Intrathecal morphine provides analgesia for 20 to 48 hours and reduce opioid consumption compared to the systemic route. The main side effects include pruritus, urinary retention, and postoperative nausea and vomiting. Higher dose, above 150 micrograms, require close monitoring in the post-acute and post-anesthetic care unit. My personal ranking for the locoregional anesthesia. In the first one, is thoracic paravertebral blocks is the best choice, but necessary high skill, it's time-consuming, and the block is not for all. In second position, erectospinae plane block. It's easy to make with a good analgesia. Continuous erectospinae plane block is possible with good outcome. This block fit for all. Intrathecal morphine administration is simple, fast, and efficient for 24-hour analgesia. In fourth position, serratus plane block is easy to make, but postoperative recovery is less than erectospinae plane block. Intercostal nerve block analgesia is good for patients who cannot benefit from another block. Thoracic epidural analgesia is not recommended for that surgery, but it may be possible for young patients with low risk of complication. An area where the anesthesiologist can impact postoperative pulmonary complication is through wall lung ventilation. A 2021 meta-analysis supports that the individualized PEEP during protective one-lung ventilation is associated with fewer postoperative pulmonary complications and improved perioperative oxygenation. However, this result will not replicate in the multicenter randomized control trial published in BGA in 2023. In their study of 1,170 patients, then compared two groups. One received conventional protective ventilation, and the other received ventilation guided by driving pressure. Driving pressure-guided ventilation improve intraoperative lung compliance and PaO2, but not reduce the pulmonary complication rate at 7 days postoperatively. Conversely, a 2024 multicenter randomized trial published in The Lancet Respiratory Medicine involving 1,300 patients compared the individualized open lung approach with a conventional protective ventilation strategy. In an individualized open lung approach group, there was an additional protocol for specific intraoperative ventilation management. A recruitment maneuver was performed immediately after selective ventilation was initiated, followed by the PEEP titration. The recruitment maneuver and the PEEP titration in individualized open lung approach group is well described in this study. Postoperatively, between 15 and 13 minutes after return to the postoperative care unit, patients are placed on room air. Patients in the control group have oxygen titration by mask to an SpO2 of at least 92%. In the individual open lung approach group, in event of positive test, patients are treated with high-flow oxygen therapy for an SpO2 of at least 92%. If the test is negative, oxygen is treated by mask to SpO2 of at least 92%. The result of the improved OLV study. Intraoperatively, the individualized open lung approach group has higher PEEP, lower driving pressure compared to the standard group, resulting in a fewer intraoperative hypoxic episode and fewer rescue maneuvers. Patients in this group showed reduced pulmonary complication at 7 and 30 days postoperative. As anesthesiologist, risk stratification is an integral part of our practice. Identifying patients at risk for postoperative pulmonary complication allow for prevention measures, close monitoring, and timely intervention to optimize recovery. Has previously been used to assess lung rehabilitation in patients with pneumonia under mechanical ventilation with good results. The lung ultrasound score has also been used as a predictor for respiratory distress after extubation in patients undergoing spontaneous ventilation with high accuracy. A modified lung ultrasound score was used in a feasibility study to detect atelectasis and different states of laparoscopic abdominal surgery. Demonstrating its feasibility in perioperative monitoring, the lung ultrasound score involves dividing the hemithorax into 6 quadrants and grading each quadrant based on lung aeration. This aeration score is assigned from 0 to 3. Score 0 for A line or fewer than 2 B lines. Score 1 for more than 2 B line or subpleural consolidation. Score 3 multiple subpleural consolidation. And for 2 multiple subpleural consolidation, for 3 is larger subpleural consolidation. Points for the 6 quadrants are added together to give a total out of 18. A Chinese team used the lung ultrasound score from 24 hours postoperatively in thoracic surgery to predict pulmonary complication at 30 days. Their study of 182% found that the lung ultrasound score in first postoperative day was an independent predictor for pulmonary complication, providing reliable prediction at 30 days post-surgery. How anesthesiologists can improve surgical outcomes. Postoperative analgesia play a key role in a patient comfort and rehabilitation. Currently, a range of regional anesthesia techniques combined with systemic analgesic help control postoperative pain. However, Recruitment and individualized PEEP to achieve optimal lung compliance are other factors that can influence postoperative pulmonary complication. Immediate postoperative non-invasive ventilation is a promising area that warrants further consideration. Lastly, the lung ultrasound score can be used to improve patients at risk of postoperative pulmonary complication, which allow for early intervention, close monitoring, and treatment adjustment. Thank you for your attention.